Hello everyone, this is Chadi Alraies from NCVH in New Orleans 2023. I'm really privileged to be with Dr. Hinan Ahmed to talk about challenging peripheral arterial problem, which is the Femo-Pop territory. Dr. Hinan, thanks for being with us.
Thanks, Chadi, and thanks, Dr. Walker, for organizing this great conference. I've been coming here regularly for several years, and every time I come here, I learn something new every time.
Absolutely.
So to focus our discussion today, honestly, when I talk about PAD, there's several challenges we have, and I think of aortoiliac disease as a separate segment. The different treatment modalities apply, and then Femo-Popliteal segment, which we see a lot of.
Yes.
I can discuss what treatment options we have for that.
Yeah.
And then the whole infrapopliteal disease and tibial is probably a separate discussion at a different time. The good news is, as I did in my talk earlier, the options for treating Femo-Popliteal disease are getting wider, bigger. We used to, at the same conference many years ago, talk about there's no data, there's no awareness, there are no tools, but I think we're making some improvement in all those areas. And it's conferences like this where you spread the awareness, the companies take notice, and then they have treatment therapies. My specific talk today was paclitaxel balloons for treatment of Femo-Popliteal disease.
Especially this topic was really hot a few years ago about the controversy about DCBs.
Correct.
Yeah.
And I think that goes again to shows how raising awareness, people went back, did retrospective analyses, meta-analyses, looked at their own data. Companies actually went back and looked at their own data. So you're right. The answer to that question has been it's been debunked. Paclitaxel is safe. We can talk about the nuances, but overall, all-cause mortality, when you look at from different studies, long-term follow-ups has been debunked. I think it's a pretty good tool. It's probably not the only tool, but it's a very useful tool when I use it for my Femo-Popliteal lesions, because the restenosis rates are so high, or were so high. Before the paclitaxel days, we would do a nice, clean, good SFA job, and the patency rates were 50%, 60% at 1 year most. And now, with all the new data, which I showed today earlier, we're talking about primary patencies in 80, mid-80s to even close to 90% rates. To maintain that lumen,
after the hard work you did to open it up.
To keep the patients from coming back, recurrently coming back to the lab, I think that's a pretty good accomplishment.
Absolutely.
The future is bright. I think we talked about in the same session about sirolimus-eluting devices coming out, having some competition. The one drug has some advantages over the other drug. To look at that data years down the road, what we learn from it, I think is going to be very helpful to us.
So from your perspective and your practice, when you do one-to-one similar to the balloon angioplasty sizing, you size it at DCB as well, or you go on a higher, bigger size?
Preferably one-to-one, maybe 1.1, but not too oversized. I think the drug delivery needs a good vessel prep, as you said. I do believe in debulking the lesion, pre-dilating the lesion, and then use the drug delivery system just to well oppose it to the wall, one-to-one, so that the drug can transmit into the vessels better.
Right. And in terms of imaging, do you use imaging in peripheral interventions, especially in the...
Yes, but it's always a relative term, how much utility are you using. Right, exactly, in the coronaries. I don't think it's 100% of the time I use imaging in my peripheral muscles. It's probably more like about 30 to 40% of the time. We did some studies with OCT imaging in SFA back when my UT days. So yes, I know the utility of imaging, plaque morphology, vessel sizing. It's a tool that's available and should be used in the appropriate patient.
Last thing is medical therapy after you finish your work on with DCB.
It's a very good question. Another area of challenge was before there was no good medical therapy for PAD patients. There is still a lot of room to put these. I'm an interventional cardiologist, so we literally use the coronary data and kind of throw it onto the PAD patients and expect it to work and hope it works. So there are definitely options. The dual antiplatelet therapy is good. Immediately post-intervention, I use it. The duration can be minimum 1 month, maybe longer, 3 to 6 months. And then for our stable PAD patients, we know about the role of rivaroxaban and the role of other agents. But it's something, again, is a fertile ground for research to see how we can specifically get good medical therapy for our PAD and CLI patients.
Right.
As you very well know, the long-term prognosis of CLI patients is still pretty bad, dire.
Right.
Yes.
Well, thank you so much, Dr. Ahmed, for your time and for talking extensively about Femo-Pop disease. Watch these videos and others on the YouTube channel. This is Chadi Alraies from NCVH 2023 in New Orleans. Thank you so much.
Thank you very much. Appreciate it.
Thank you.